Hey, everybody, welcome back to the Overrun Podcast. My name is Ed Bowder.
I'm Dan Schwester.
And today we're really excited. We have Eddie Joe Gutierrez here. He's an intensivist who specializes in vasopressors. You can find him on Instagram at Eddie Joe MD. Eddie, thanks for coming to join us, man. I appreciate it.
My pleasure. Thanks for inviting me to the party.
Yeah, we're happy to have you. We've been talking about having different specialists on all the time, and we don't talk enough about pressors and EMS. So we wanted to bring you on, kind of talk about what the status of what's the state of the science, I guess. And try and break apart some dogmas that we may have heard previously in the field. So I want to start and kind of hit the ground running here. Talk to me about peripheral IV access and vasopressors, because in the field, we typically don't see patients with central lines. We usually can't float them. Do they work? Do they not work? Are they good? Are they bad? Fix all the problems in the world. Eddie, go.
Sure. I'll be happy. First, disclaimer, as always, a lot of this data with regards to peripheral vasopressors is from not the pre-hospital setting where you guys all run into the fires, jump into the mayhem, the chaos. There's no way to randomize patients in your setting. So we got to make that very clear. We're just trying to do the best. We all are just trying to do the best with the data we have and save some lives. And sometimes, you know what? We got to go against the grain. We got to not use data in some cases just to save people's lives. So in the case of peripheral vasopressors, you guys don't have all the goodies we have. I mean, I use a little ultrasound to place the central line. I have all my monitors. I have all my technology. You guys don't have that. You guys have a patient who's dying. They're dying in your face. They're dying in your arms, and you have to do something, because doing nothing is not an option. Therefore, the utilization of peripheral vasopressors is your only option. If somebody gets mad at you for that, question their intellect for that matter. But that being said, there has been a good amount of data. None of it is double-blinded, placebo-controlled, et cetera, because that's just stupid in this case. And I'm going to speak in a way that's a little bit human, and I'm not going to speak like a scientist here, because we're just trying to get points across. At least in my opinion, that's the way I roll. Sorry, I wasn't born speaking all this medical jargon.
No, that's perfectly fine. I'd rather have people understand how things work than understand the jargon. Right. Saying like, well, you have to be careful when you're establishing peripheral IV access, because establishing peripheral venous access might cause necrosis of the tissues. It doesn't really get a message across, say, from like, well, if his heart doesn't work and you have an option to do something to make the heart work, let's do that.
Right. Well, exactly. Along those lines, you have to start something. The patient's hypotensive and they're not responsive to fluids. The other thing is that you all don't have the luxury of lab testing, echocardiograms, things of that nature that I have, right? So, no, in my career, I've never heard somebody say, the pre-hospital folks, they could have done this better, because we all know that you all are stuck. You guys have 3 tools in your tool belt. I'm exaggerating. I know you have 6. But you guys have 3 tools in your tool belt, and it's usually just fluids, a little bit of pressors, and a gas pedal to get the patients to the hospital as soon as you can. So if you're giving the patients fluids, and that's not working, well, then you need to do something else, right? Because insanity is doing the same thing over and over, expecting different results. And people love to give fluids. The sepsis protocols love to give people fluids, but the reality is that fluids are only helpful to a point. Now, that being said, you need to establish IV access to start the patient on peripheral vasopressors. Starting off with the location to place these IVs, it's better to not go in the hands. If you do have a risk of having extravasation and peripheral necrosis and all those things. So the higher up you could start the patient on the peripheral vasopressors in a nice, safe IV that does flush and it pulls back without any issues, then go ahead and start it. We have the luxury in our institutions to have limits of sorts of how high you could use your vasopressors. So for example, we have this made up number of 10 micrograms per minute of norepinephrine, for example. We have these made up numbers of phenylephrine at 100 mics per minute, for example, running through a peripheral IV. But again, those are numbers, number one, are arbitrary. Somebody made them up. Number two, what?
In medicine?
Seriously, you mean like the 30 cc's per kilogram that we use in sepsis? Yeah, there's no randomized control trial where they gave somebody 20, 30, 40, and 30 was the best one. Somebody just basically picked this. I know there are a bunch of people who would be mad at me for saying that, but it's the truth. I looked for the data. Trust me, I have a fun time proving people wrong, or at least like trying to. I end up proving myself wrong in some cases. I'll give you an example for that in a second. But
Well,
nonetheless,
that's half the fun with data, right? Is that it's you might have a preconceived notion that gets challenged by it. So and just to because I want to walk through the process, right? So we find someone who's hypotensive. All right, now we can establish a peripheral line. For I guess there's sort of an impression, and I don't know if it's a time constraint, where you have to get fluids in to kind of like prime a pump before you start actually using vasopressors. True or false? Do we care about that at all, or is it? And I'm guessing where this is going. The patient is dying. They're very sick. Just go ahead and fix them.
so the most recent data, there was actually something a little bit more recent, but there's two trials that came out in 2020. Now, for those of us who are in healthcare in 2020, we had other things to worry about than
It was a great time. There was nothing happening. It was a calm time.
we're all hanging out, just taking care, like looking into COPD studies, right?
Yeah.
Um, but that being said, there were two trials. One of them was called the sensor trial that I can recall off the top of my head. By the way, all these data are in my book, The Vasopressor Nitro book. So you can check that out.
Beautiful plug. Beautiful plug.
it.
Love that.
Love it.
Well, while we're here. But one of the things that they did in these two trials was that they looked at the patients who received very early vasopressors versus resuscitation, then the vasopressors after. And in these studies, they did notice that there was a quicker uh, they reached their goal of hemodynamic stability faster in the patients who received early vasopressors. There was no increase in ischemia of the digits, of gut ischemia. There was no increase in MIs, other outcomes that they looked at that I can't remember off the top of my head. It did demonstrate benefit to starting patients on vasopressors earlier. So what I do in my practice is when I have a patient who is hypotensive, I just start them on the vasopressors immediately. I just go ahead and I order norepinephrine. Norepinephrine is your go-to vasopressor, as it is what we use primarily in patients with septic shock, but it could also be used as first line in cardiogenic shock. That was demonstrated in several small papers, but still nonetheless it is beneficial. So you just start patients on norepinephrine while you're resuscitating them, and then you reach your MAP goals faster, your lactate normalizes faster, and then you can just peel it off once you're done resuscitating the patient.
No, I like that. I think we've been kind of indoctrinated to this. We've got to flood them with fluids, especially in septic shock. And I think like Eddie said, that makes a ton of sense. It might work with some people, but if you don't get that responsiveness, you don't see them getting better. You shouldn't be afraid to put people on a vasopressor. It's not it's not as bad as you think it is, and it may actually have some good benefit for them down the road.
So along those lines, there were a couple of sepsis studies that have come out over the last 25 years that have demonstrated how we have been cutting down the amount of fluids that we've been giving patients in resuscitation for sepsis and septic shock. All of us trained, all of us who are in the hospital field under this early goal directed therapy mindset of the Manny Rivers trial that was published in the New England Journal of Medicine. Can't remember off the top of my head, 2001 or something like that. And in those studies, they gave patients 9 liters of IV fluids for resuscitation. That's a lot of fluids.
Yeah.
A lot of fluids.
It's doubling your volume.
And
it's like those old fiber cereal commercials. Like, oh, you'd have to eat 27,000 bowls to make the like it's just like, oh no.
Sorry, I remember those commercials. I haven't thought about that in about 20 years. Or maybe longer for that matter. Holy cow.
I watched a lot of TV as a kid. My parents loved me.
Yeah, I think you just made my day with that. Now when I feed my daughter cereal, I'm gonna think about that. I guess we give her.
It's interesting. It's interesting you talk about early goal directed therapy, because I think that's like the first real FOMED kind of phenomenon that came in. Everybody got on the board. Everybody jumped on the wagon on this because they heard it on a podcast. And then we found out it didn't really work well. And it's kind of been debunked at this point, but these guidelines still are kind of hanging with us.
It has.
It's been taking a while for the vasopressor like camp to kind of start going forward, because we've always had this stigma about vasopressors. And I remember I'm the older medic. I've been around a long time. I remember Levophed, leave them dead. And, you didn't start, dopamine unless they were like, 30 over zero and they were circling the bowl. And that's not true. What we're starting to see is the opposite was true. And maybe you can speak to that. Like, this stuff does help people. It does work. You have to be comfortable with it. And that's what I liked about your book, was that it's very straightforward. It gives you a really good overview of things. It talks about the relevant studies that matter and why one might be a better choice over the other. But here's it was very easy to follow. And I guess where I'm getting at with this long-winded thing is, you talked about norepinephrine, and why do you think that? Tell us why that's a front line for you. Why do you like it? What does it work? What does it do for you? You've got somebody who's dying in front of you. Why do you think that's going to give you the best bang for the buck?
Well, it comes down to first of all, thanks on the compliment on the book. I appreciate it. I did it like that because I'm not that smart, really. So so I had to write it in a way that I would understand it and enjoy it myself. But that being said,
It worked.
Oh, appreciate it. When you create something like, for example, you guys creating this podcast and me creating all my own work, my big thing is like, is anybody gonna like it, or is anybody gonna understand it, so it's been refreshing that it doesn't suck, because I just didn't want to throw out a turd sandwich out there. But getting back to the norepinephrine conversation, the thing about norepinephrine from a mechanism of action standpoint is that it hits both the alpha receptors primarily, but it also helps the beta receptors. When you compare it to, for example, and from a receptor standpoint, how that works is leading back to the equation MAP is equal to cardiac output times systemic vascular resistance. If your blood pressure is low, if your mean arterial pressure is low, it's either going to be the heart, the plumbing, or both, right? It's people overcomplicate hemodynamics, but it really shouldn't be that way. So if you have a patient who's critically ill, your beta receptors are going to help that cardiac output, and your alpha receptors are going to help out your systemic vascular resistance. So what does norepinephrine do? It hits both of them. And therefore, you will have an improvement in the patient's cardiac output and an improvement in their systemic vascular resistance, either of which or both will end up helping out the mean arterial pressure. So that's how you end up using norepinephrine as your first line vasopressor, because it hits both of those receptors simultaneously, and therefore hopefully improves hemodynamics. When it comes to comparing it, for example, to other vasopressors, let's say phenylephrine. Phenylephrine is pure alpha. So in your MAP is equal to cardiac output times systemic vascular resistance equation, it's not going to do anything to help out your cardiac output because it doesn't touch the beta receptors. It's only going to hit your systemic vascular resistance, your alpha receptors. So what's the issue there? Well, if your cardiac output is already low and you use phenylephrine, arbitrarily as your first line vasopressor, you're going to suffocate the cardiac output by increasing the systemic vascular resistance too much. And yeah, your SVR is going to go high and your blood pressure is going to look good for like a couple seconds, but then it's going to create too much afterload. It's basically going to put a clamp behind your heart, and therefore you're not going to be able to generate a blood pressure because you're having this adverse effects of phenylephrine.
Yeah, I think that's a really, really straightforward way to explain it. We get away from this. I think breaking it down to mean arterial pressure and what your cardiac output is and what your SVR is, and how you tweak that. And that's a theme in the book, is that you keep going back to that equation and you show how each pressor works on the different parts of the equation and what you're going to get out of it. I just have one more thing, like epi versus norepi. My partner, Jenna's my partner. We work together a lot. She is absolutely a genius when it comes to this stuff. And I'm an old school, old medic, and I like epinephrine drips and she likes norepi. So does it matter? Who's right?
I'm gonna go ahead and I'm going to state this from my personal opinion. I don't care. Just get them there alive.
Okay.
Right?
So so that's some of the best, that's one of the best answers that I've heard in, the 7 years we've been doing this show.
Yeah.
So I worry that a lot of times in research and in data, people are looking for something that it gives an absolute answer, right? People look for finite kind of boundaries for things, which is like, that's how you get leave a fed, leave him dead kind of thing. Like just don't use that drug. And Danny, you and I remember when, out in the field, it was like, if you have someone who's hypotensive, you're going to give them fluid, you're going to give them dopamine. Like
Mhm.
that's it. Like I can remember the struggle to get dobutamine onto trucks, a decade ago. And in the end, it feels like a lot of times these arguments just kind of come down to fix them. Like it doesn't really matter what we're using. It's what your favorite pressor is really more of like an academic debate, which are great. That's what we do here all the time. But am I getting that right, Eddie? Is that kind of like just do the thing, fix them first, and we can have the discussion kind of afterward?
Absolutely. And I'm going to give you a great example of a case that uh, a friend of mine told me about at some other institution that's not mine.
I know a guy who worked at a place and he saw a
We
thing.
know that place.
Yeah,
We know
Right,
that
right.
we
place.
get
Yeah.
that. Yeah.
But
Yeah.
a patient came in with septic shock, and they were started on the first line vasopressor, which is norepinephrine. By the time that the patient arrived in my friend's ICU, it was noted that the patient had severe aortic stenosis and they were tachycardic. And so the intensive care doctor said, hey, let's just not use norepinephrine anymore, and let's just use phenylephrine so that we do not increase the risk of tachycardia and AFib in this person with severe aortic stenosis, and we could get them better. And so,
And that's an interesting point too. The unseen diagnoses and kind of like the almost like the long-term pathology risks that we might see in the field. We don't have access to, is the patient predisposed to aortic stenosis, or half the time we're lucky we can get any history, let alone a reliable history. So when we talk about risk reduction, risk mitigation, it might just make more sense to give Levofet. Just its risk profile might be lower, which I'm not sure is being discussed in pre-hospital medicine a lot, because again, I think there's still a lot of 10, 15-year-old infighting between team alpha drug, team beta drug, and then team alpha beta drug. And I think kind of in the end, the signal almost gets lost in the noise. Because so talk to me. We've talked a lot about septic shock. Talk to me about cardiogenic shock, and I guess some of your tips and tricks for that. Because sepsis is something we see in the field. I think that we've almost gotten away from like, all right, we're going to fix it. There's pre-hospital antibiotic data that isn't great. But we do tend to run into people whose hearts just aren't working anymore, specifically in the elderly. So that patient you mentioned who had aortic stenosis, that jumped into my mind, because we see those patients and we don't typically know their long-term follow-up. So talk to me about cardiogenic shock and your approach to that in your particular unit.
Sure. So cardiogenic shock gets a huge rabbit hole with a lot of nuance, but we'll try our best to.
Nothing but time, baby. It's a podcast.
We'll try to knock it off. But the first thing you guys should do, obviously, is check an EKG on these patients, make sure it's not a STEMI, right? That's the first thing you guys do, and it's actually the most common cause of cardiogenic shock is ST elevation myocardial infarction. And in those people, you have your tricks and all that, and try to give them a little bit of fluid here and there, and give them their nitroglycerin and all the other goodies that you guys do. Not gonna interfere in how y'all manage that. But if the patient is hypotensive and it's not a patient who is in cardiogenic shock from acute coronary syndrome, it becomes a little bit trickier, because from your standpoint, you're seeing a patient who is hypotensive and looks kind of like shock until you touch them and you see that they're cold instead of warm. They could also be tachycardic. It becomes a little bit tricky. And this is where a physical exam is helpful. Some of these cases with decompensated heart failure, for example, they're edematous, they're struggling to breathe simultaneously, they're all crackly. It's challenging again, and this is why I don't envy your position, because I have labs by the time they get to me, right? I have right. You guys have your stethoscope and have to go by the sounds that you all learned in the textbook, which you guys know that The sounds that you read in the textbook did not read the textbook when it comes to
Listen. Ronkai does kind of sound like blowing bubbles in a milkshake. I'll say that it sounds a little bit like that.
But absolutely. But so when you examine the patient, that they're cold, they're not well perfused, is somebody who this has been coming up on them a little bit longer. Sepsis is usually a faster insult from discussing with their family. Hey, they were fine yesterday, but today they're just febrile. They're not feeling well. They're not making as much urine. They have this cellulitis on their leg. That's a little bit easier to figure out. But in patients with cardiogenic shock, that could be a little bit more tricky, although it's a little bit more gradual in terms of their decline. And so those folks as well, giving them fluids could be deleterious to them. That's why I'm not a fan of the sepsis protocols and arbitrarily giving everybody fluids, because if these patients have LV or an RV for that matter that's already overloaded, giving them more fluids is just going to add weight to the dumbbells that they're trying to curl, and they're already struggling with the 10-pounders. So putting those patients on norepinephrine has been demonstrated to be a good first off the bat vasopressor that we could use. There was a particular trial that they were doing on patients who were in cardiogenic shock, and these were acute MI patients, not decompensated heart failure patients. But they were giving patients epinephrine versus norepinephrine in the acute myocardial infarction cardiogenic shock patients, and they had to stop the trial early because they stopped it so early that it was not powered for mortality. But they were finding that the patients who were on epinephrine were dropping like flies. It was such an extent that the researchers had to say, no, we're not doing this anymore. We're not continuing this. We just do not recommend using epinephrine in patients for cardiogenic shock from acute myocardial infarction. Now, when it comes to patients with decompensated heart failure, well, you might need to use a little bit of epinephrine in that patient population if the norepinephrine isn't cutting it, if you want a little bit more beta action. But it becomes very challenging from a pre-hospital front. Again, I just keep on reiterating this over and over again, how I would be terrified to be with you guys because I'm so reliant on all the goodies I have. That where I could, for example, start somebody on an inotrope and then do an echocardiogram on them and see how they're doing, or float a swan in them and see how they're doing, or hook them up to different machines where you all don't have that luxury.
And there is a movement, for pre-hospital ultrasound that's out there that I think it's gaining a lot of traction. I think that big picture, I think that a lot of people are trying to physically move the ER or the ICU out into the field, and I appreciate the deference that you give, because like there has to be kind of a separation, right? There is only so much that we can do out in the field. And like we talked about earlier, I think people try and find like sort of a magic bullet type of solution. One thing I do want to talk to you about is a little bit, because and I know that we talked about a lot of medical shock stuff. We talk on the show about like whole blood administration in trauma. Do you have a pressor preference in traumatic injuries, and with the understanding that fluid and whole blood are frontline to fix the things that you lost? But give me some of your feedback and insight on traumatic patients.
So let me go first into the traumatic patients and my insights, and then I'll go back to a statement I was going to make about point of care ultrasound.
Yeah, great.
So I do not work at a trauma hospital. I have not
You lucky duck.
I have not worked in that. And it's purposeful, to be honest with you. I never liked it wasn't for me. I like other things, but trauma's not for me. Yeah, I can deal with other surgical patients. I do. I mean, I run a cardiothoracic intensive care unit, so we do a lot of transfusions there, but it's not the whole. I wish we had whole blood. There's a gentleman who is military that speaks in a lot of the national conferences about whole blood administration, and I recall listening to him about a decade ago and just falling in love with the concept. Now, I have not followed through with the data because it's not relevant to me, and I got other things I need to be an expert at before I could try to do that. So,
perfectly acceptable. Yeah. Totally get that.
And then reading the literature with regards to trauma and vasopressors, I mean, it just becomes source control. It just becomes source control of the bleeding and resuscitation, and hopefully, you will need some vasopressors because there is some vasoplegia. In other words, a decrease in the patient's systemic vascular resistance that takes place because of the inflammatory properties of the trauma, of the blood, of the hell that the patient's gone through, their acidosis and all that. And in which case, from a conceptual standpoint, norepinephrine would be the one that makes the most sense, just to keep the patient alive. Now, going back quickly to the commentary you were making about pre-hospital utilization of point-of-care ultrasound, I do have one very big factor that I want to mention to you all that I'm not sure you all are aware of. The majority of critical care doctors are not good at point-of-care ultrasounds. A lot of critical care doctors, board-certified intensive care physicians, are not comfortable doing echocardiograms at the bedside. That is a extra step that a lot of us take, an extra initiative in order to have that skill set to be able to do that proficiently. And if you consider how many critical care doctors there are relative to how many teammates you guys have throughout the country and in fact throughout the world, it's going to be challenging for everybody to have the same level of training, the same level of competence, the same level of confidence to be able to appropriately assess patients. So I really have to tip my hat to your colleagues and your partners and your cohorts who are trying to excel and going the extra mile. I definitely recommend that. But at the same time, please keep in mind that even from my standpoint, from the critical care doctor standpoint, most of my colleagues are not on the same boat. Thankfully, there's a shift that's taking place in training right now in residency programs as well as fellowship programs where people are becoming more highly skilled, more trained at it. But that's only been taking place over the last 5 to 10 years. That's not something that has flooded our healthcare system just yet. So I just want to put that into perspective so that people who are still trying to learn the ABCs and learn the basics of doing pre-hospital work, adding point-of-care ultrasound is great, but learn to walk before you could run.
No, I think that's absolutely
That's
right.
a great point. Yeah.
And I think that just real quick, Dan, I think one of the things with POCUS and pre-hospital ultrasound, it is kind of a new toy, right? And because it's kind of the new sexy thing, everyone really gets into it. But I do enjoy I think it's important to reinforce, like, it's not, specialists aren't bad at it because it's a bad skill or they don't do it. Specialists are bad at it because it's just another thing to do. And by the time we get to them, patients are usually sick enough that they would need something like ultrasound. So I don't want it to seem like it's an apathy thing from the specialist standpoint. It's one of those things that you use it for patients who are in such extremis that you probably wouldn't use it anyway. But go ahead, Tim.
I think, well, first of all, I think it's a matter of focus. I mean, you're seeing the field as opposed to a tunnel vision view of one little thing. But I want to get back to the book because I really got a lot out of it, and I've been going back to it, and I've been using it with the students we precept, and I know, again, going back to that equation, MAP equals cardiac output times systemic vascular resistance. For somebody who's trying to learn how to use the pressors that they have available to them, is that a good way to look at it? Like, so that you can kind of understand, hey, I've got a patient in X. I want this to happen. I want this to happen. Therefore, this is probably the best agent to go with, as opposed to if I have one or two, do I pick this or do I pick that? Is that a good way to look at it? Or is there a better way to start to try to understand this?
Well, if you are pressed for time, and in your field, you are pressed for time the majority of the times, just starting with norepinephrine is the way to go. It's going to just buy you a little bit of blood pressure until you have the time to sit down, put the pieces of the puzzle together to think about what the actual etiology is. What other tools do you all carry with you, and rather than just norepinephrine, what else do you have on your
Well,
shop today?
we've got norepi, we've got epi, we've got phenylephrine, we've got dopamine.
Okay.
And some places still have dobutamine on the truck too.
Yeah. I mean, the only time I would use dopamine, for example, is in patients who have symptomatic bradycardia. But in those cases, you could also reach for epinephrine as well, if that's what your prerogative is.
So
So
basically, what you're saying is, all this is academic. What matters is recognizing the need for a vasopressor, getting that vasopressor on board, and getting that increase in your mean arterial pressure, because that's pretty much the ball game.
Yeah, when a patient's hypotensive, they're not perfusing their organs. The longer that they are hypotensive and not perfusing the organs, that's when they come to us with their kidneys already hurt, with acute kidney injury, with ischemic hepatitis, or an increase in their liver function tests. And you have that elevated lactate and a persistent metabolic acidosis that just becomes more challenging for us to manage in the hospital. So restoring the patient's mean arterial pressure, whatever way you want to do it, just get it done, and it's going to end up being helpful for the patient. It takes place in critical care in so many times, so many different facets in the ICU, where it's 6 of one, half dozen of the other, and then we end up citing trials that had a number of different flaws that make the trial null and void. But since it got published in this fancy journal, then we think it's the, I don't know, the best thing since sliced bread. And in fact, when you really look at all the detail, you're like, yeah, this kind of doesn't matter. It's irrelevant.
Well, I always go back to Andrew Wakefield's paper was published in the New England Journal of Medicine and the Lancet. That, like, in the end, there's always the possibility for error. I do want to talk about RSI real quick before we get out of here. And I imagine that those listening will understand that the crux of it is just do the thing, make the patient better. Add norepinephrine to your formulary, just have that with you. In an RSI setting where we're giving someone a paralytic, whether it's succinylcholine, rocuronium, I'm sure places are still using vecuronium. We have a sedative like ketamine, we have like fentanyl on board, or morphine, I'm sure, and probably in some shops still. Is there any different takeaway message other than have norepinephrine available to you, or do you have a preferred other pressor in the RSI setting?
I, again, have the luxury of knowing the patient when they show up in my ICU. Even my ER colleagues sometimes don't even have that luxury, even though they have the medical record number, they can pull things up. Might be somebody who's never been there before. So I tailor what medication and how I expect them to, I guess, compensate or not compensate for themselves for their RSI. And so I could choose based on that. However, you guys don't. And again, this is just a commentary as well as a compliment to you all for what you do, and an appreciation that you guys don't know if the patient has aortic stenosis, you don't know if they have RV failure, you don't know these things, and in which case you're just going to do your best. And if you have to reach for a pressor, I will say it again, norepinephrine is going to be your go-to. I hate to. We spend X amount of minutes on this podcast, and it should just be like, just use norepinephrine.
Just use norepinephrine. No, but I think that's great though, because again, these conversations are fun, right? But I think that, and not to put too fine a point on it, but when you get into, say, like the QA process, I think it's very easy to go through and look at a chart and say, like, well, looking back on it, it's possible that maybe a different pressor might have worked better in this type of setting. Right. And having that academic discussion where, like, all right, well, we found out that the patient had impaired renal clearance, and they had a long history of renal failure that you didn't know about. So when you did this, you might have caused more, renal infarction. Like, okay, the patient's blood pressure was 60 systolic.
Right.
So I very much appreciate hearing, like, just do the damn thing and fix it.
Like, the kidneys have to be alive to be injured, right?
Yeah, the patient has to be alive to survive.
So along those lines, like, I've been out of training for approximately 8 years now. And in these 8 years, I've been taking care of critically ill patients that the vast majority of them have been dropped off by our pre-hospital teams. Not once have I had one that they were like, oh yeah, they should have used a different vasopressor. That has not come up once. I just want to make that very, very
okay. Never got that note in morning rounds.
No, I mean, we've heard the comments of like, oh yeah, the EMS folks, or the pre-hospital folks intubated the esophagus and then they struggled with the airway and this, that, the other, in which case we're like, okay, airways are hard. Airways are in the field are hard, but it's never been a vasopressor question that has come up. I have given some of my ER colleagues a hard time about things just because I'm a pain in the butt. And it's like, maybe you shouldn't have done that. In which case, I try to be nice about it because I think I'm a guy.
And again, I think that having the academic debate is fun, but in the end, for all of the platitudes we throw out about how we're out there to save lives and improve outcomes and all that, and it's kind of like, okay, well, if that's the case, then we should just do this, right? We can, years ago we were having it feels like the same conversation about ketamine, where
that's my favorite. No, not that ketamine is my favorite. The debate on accommodating ketamine.
The giving it to patients, administering it as a care provider. But the data kind of started to show that there were more reasons to give ketamine than to not give ketamine. And I think that that's kind of what we're starting to see with the shock data, where you can say like, all right, well, I'm going to compare, this versus that, but it seems like just give the thing that works, right? Like, and I think that to an extent, like norepinephrine might be easier than an epinephrine drip or a dopamine drip or whatever else. But yeah, that was kind of the biggest thing. But so I guess if you have a take-home message for all of us, and I feel like if you've been listening to this, it's pretty clear that. So what's your one biggest take-home message about using pressors in the pre-hospital environment?
Sure. My big message is restore perfusion as quickly as possible by any means necessary. So if that means starting them on peripheral vasopressors, try to establish something in the forearm and get something good, something that works. If the patient is somebody who you found in cardiac arrest, slam that IO in. Do what needs to be done to get the medications into the patient as soon as possible. Obviously, do it as safely as possible. Make sure that there's good return and it flushes well and there's no extravasation, and then we'll take care of it when they get to the shop. We'll take care of it when you get to the emergency department. We have all the tools, we have all the toys. There's no need to try to be a hero in that sense and try to put a line and subclavian on the field. I'm not sure if you guys have privileges to do such things, but that's the way that I see
it. It took us 10 years to be able to put an IO in the shoulder. one day, yeah. It's eventually we might.
What I'm getting from this is just get me the ball. Just get the ball up the floor and give it to
me. Just fix the patient. Just do it.
Just bring him over, and then sorry, and then from a vasopressor standpoint, I mean, just start him on levo. Start him on levo. Make the blood pressure pretty. Try to save the organs and make sure you restore perfusion and get them over to us. We got the rest.
I like it.
That's beautiful. I think that's a great place to leave it. Give norepinephrine, give Levophed, get to the hospital. Eddie Gutierrez, Eddie Joe MD on Instagram. He is the author of the Vasopressor and Inotrope Handbook. Go and buy it. It's oh yeah, we all got it. Yeah. Go and buy it. We're not getting any money from Eddie for this. It's one of the best books that you can get to improve your studies and improve patient care. Eddie, thanks so much for joining us, man. For the Overrun, I'm Ed Bowder. He's Dan Schwester. We'll talk to you all next time.